super loaded question to begin with. Which of these fractures is the most interesting fracture in this evening that we're going to talk about? 1, 2, 3, or 4, let me know. So 1 should have a talus fracture, which obviously we've talked about, but you get asked the same thing in the trauma meeting all the time, blood supply and Hawkins. 2, calcaneal fractures. I'm not sure Mr. J. Seelin will lead us into knowing whether to fix these or to not. No one really knows. 3, ankle fractures, which are so common. And 4, Lisfranc fractures. So which of these is the most interesting? Let me know. Yes, well done, guys. So we're going to talk about Lisfranc fractures, and they are quite interesting. And who is Lisfranc? So Lisfranc, which of these guys was a Lisfranc? He was a French surgeon who was also a gynecologist. And I'm sure his name has come up in lots of different other orthopedic pathologies and anatomy. So which one of these guys is Lisfranc? Jacques Lisfranc. I think there should be a poll. And then we'll crack on. Oh, 50-50. The answer is number 1, actually. Number 2 is actually Charcot, who talked about Charcot foot, but that's not for this talk. So to understand Lisfranc fractures or pathologies, we need to understand some anatomy. On the left, you can see a plantar view of the right foot. And when we talk about the foot anatomy, we talk about arches. So you've got a medial and lateral longitudinal arch and a transverse arch, which you can see. The medial longitudinal arch is the arch you can see in most people's foot, made up of the calcaneum, the talus, navicular, medial cuneiform, and the first metatarsal. The lateral longitudinal arch is on the other side, and the transverse arch you can see on the left-hand image is due to the metatarsal heads. On the right-hand image, we also have a transverse arch in the midfoot, and this is the arch that's disrupted during a Lisfranc injury. The Lisfranc joint we talk about is the midfoot arch created between the medial cuneiform and the base of the 5th metatarsal and all the bones and joints in between. You can see that your 2nd metatarsal is recessed in to your intermediate cuneiform. So if you look on the image on the right, it acts as a keystone, and that keystone is the key to stability of the midfoot. And this keystone, or this joint being disrupted, leads to the long-term sequelae of a Lisfranc injury. And here you can see, so we talk about the Lisfranc ligament, and actually the blue ligament, interosseous ligament, we talk about the Lisfranc ligament, but it's actually, there's a dorsal ligament as well, which is weak, and plantar ligaments underneath, which are stronger. So the injury is a combination of bony injuries of the joint and ligamental injuries as well. And here you see it again, a schematic on the right. The left-hand image doesn't come out that well, but the schematic shows those ligaments again. So how do people get these injuries? There are a few mechanisms. The commonest mechanism that I've seen is people through a sort of medium energy injury putting an axial load through a hyperplantarflexed foot. So the energy is transmitted up through the metatarsal heads, through the metatarsals, through the TMTJ joint, and then you get disruption of the ligaments and the bones. You can also get it, obviously, with energy going the other way, as you can see in that middle image. So the image with the American football player landing on the foot. And you can also get it in high energy trauma, such as motor vehicle accidents, when somebody crashes headlong and you get energy going up to the dorsal aspect of the foot, disabling the TMTJ's ligaments and bones. And then we also have to classify these injuries. So it's not something that we get asked a lot in the trauma meeting, but there is a classification system to describe when you get those injuries to the TMTJ, the remaining congruency of the joint, as well as the direction in which that the incongruent joints have gone. So whether they've gone medial or lateral. But we don't use it this often. So before we get on to some of the radiology and some of the surgical management, we have to talk about immediate management. So if this patient comes in, is a trauma patient, polytrauma, lots of systems involved, they get managed by ATLS. And if it's an open injury, you always follow the BOST guidelines for open fractures. If it's an isolated injury or an obvious injury, these patients need a 3-view radiographs. They need to be put into a back slab with the foot in neutral or plantar that's for pain relief. And they need given appropriate analgesia. They also need thromboprophylaxis because they're going to be non-weight bearing whilst you do any further investigations. And those further on while we create a plan. And that further investigation is a CT scan to not only plan your operation, but there may be other subtle midfoot injuries around. In the high energy injuries, you can get complete dislocation of the TMTJ medially or laterally, and you can get quite severe bony injuries in the midfoot, all which require a CT scan in order to plan for the operation that these patients need. Consider if they've got quite a severe dislocation, whether an attempted reduction maneuver is worthwhile in A&E, although commonly, unless it's highly unlikely it's going to be successful, and we have to be put into a good back slab, consider a full POP with a strip taken out to control the fracture as well. But this has a low success rate in the A&E setting. So what if the injury is subtle, or you have normal x-rays but they've got pain, or there's a delayed presentation? What is going on here? Is this just a bit of bruising and there's nothing to worry about? This person is complaining of midfoot pain. Are you really worried and they need admission? Or you're suspicious of something, let's get some further imaging. What do you guys think? Let's see. So yes, I think you guys know plantar ecchymosis is not pathognomonic. It's suggestive of a midfoot Lisfranc injury. Other midfoot fractures not related to the Lisfranc can cause bruising as well. If the patient is obviously part of a polytrauma with multiple systems involved, they're going to get admitted, they're going to get a back slab and further imaging as an inpatient. But if this is an isolated injury, you can do everything in A&E, plan a CT either before they go home or in the next few days, keep them non-weight bearing, and then let them go home. So midfoot pain, plantar bruising. Some people talk about instability, but they're very painful. So I doubt you can really recreate the instability of the injury. Okay, let's talk radiology now. The key to the initial diagnosis is having those 3 views, because those 3 views, the dorsoplantar view, the oblique view, as well as the lateral view, all show you something that helps in the diagnosis of this injury. In the dorsal plantar view, you draw a line down the medial aspect of the second metatarsal, and this should line up with the medial side of the medial cuneiform. So the yellow line and the red line should line up. And if they don't, we can think that this is most likely a Lisfranc injury. There's also widening between the first and second ray, more than normal. Again, suggestive of a Lisfranc injury. You can get a flex sign, which is a bony avulsion of the Lisfranc ligament we talked about earlier, as you can see with the yellow arrow there, which again is diagnostic of a Lisfranc injury. This fleck can come off either side, either the base of the second metatarsal or the medial cuneiform. On the dorsal radiograph, we're looking at displacement of the metatarsal bases in relation to the cuneiforms. Commonly it's 1 or 2, but can, depending on the energy of the injury, be all of the metatarsals compared to the cuneiforms. On the oblique, if you can focus on the blue and the green lines, we're looking at the medial side of the base of the fourth metatarsal to line up with the medial side of the cuboid. That's the blue line. So if there's any disruption there, there may be injuries to the lateral rays, the fourth and fifth. And in the green line shows the medial column disruption, the medial part of the metatarsal in relation to the medial cuneiform. And both of these are seen in the oblique view. Sometimes the radiographs look normal. They've just got some bruising and we're still not sure what's going on. So we still are suspicious. The history, the examination are all suspicious, but the radiographs don't prove anything. What we can do, get some weight-bearing radiographs, probably when they come back to fracture clinic. And you can see the green arrow pointing to a wider space between the first and second rays compared to on the right compared to the left, which would indicate a Lisfranc, most likely ligamentous injury. So let's talk about how we operate and what our principles and our management are. We've put them in a back slab. We've got a CT. There's not much soft tissue around the midfoot, especially when we're doing surgical incisions from the dorsal aspect. So if there's significant swelling, which there normally is, let it settle down, send them off home, tell them to keep their foot elevated, and bring them back for regular swell checks. What are our surgical options? Broadly speaking, they are open reduction and internal fixation or arthrodesis, fusion. Most people get an open reduction in internal fixation. These are via dorsal skin approaches. And when you're in theatre with your boss, your principles to discuss with him is how are you going to assess for the injuries and how are you going to fix them? The way I do things is I work from medial to lateral, and I work from proximal to distal. So I'm looking to fix the medial structures sequentially from the first ray to the middle rays to the lateral rays. Your medial rays and your middle columns are originally fixed with plates or screws, and your lateral rays are normally biomechanically slightly mobile when people walk normally. So we would temporarily fix them if there's a lot of movement and remove those KYs in 6 weeks. Commonly, if you fix the medial and middle columns, the fourth and fifth previously unstable TMTJs restabilize and they don't need wires. The only caveat to open reduction and internal fixation is in a purely ligamentous injury, or perhaps in a delayed presentation, we would consider fusing the midfoot primarily. And the paper from Coetzee in 2006 is the one that's quoted with regard ligamentous Lisfranc injuries and primarily fusing them. So what is your approach and how many incisions are we doing? One massive incision? Are we doing two smaller incisions? Or are we doing three or more than three? The more incisions, the better. Or does it really matter? So, sorry, there should be 4 choices in that. Let's see what the polls say regarding those. Oh, hang on. 2. Okay. So, I would say it doesn't actually matter. A lot of it is how you've been trained. A lot of it is what the soft tissues are like after the swelling has gone down. And a lot of it is just understanding the anatomy to plan your operation. So classically, everyone used to do this via 2 incisions. The medial incision is quite dorsomedial over the base of the first metatarsal and the medial cuneiform for plating. So on the medial side of EHL. Your more lateral incision should be far enough away to create a sufficient skin bridge between the 2 incisions. And you can access the second and third metatarsal bases so that you can plate them. You commonly don't need the lateral incision, as I say, by rigidly fixing the middle and the medial columns. The 4th and 5th rays don't really ever need anything doing. But it can also be done all through 1 incision if you want. This is from a paper from Australia by Philpott, which uses 1 large incision centered over the second metatarsal. And once you go in, you create 3 windows. So you go medial to EHL, you go lateral to EDB, and EDB is protecting the neurovascular bundle. And then you go between the 3rd and 4th EDL tendons to access any lateral structures that you might do. And you can do this, and it's entirely appropriate to do this approach as well. Beware your neurovascular bundle. So your dorsalis pedis artery starts around between your fixation of your second metatarsal and your first metatarsal, as well as the deep perineal nerve. So those are the main neurovascular structures to be aware of. And there are many ways to fix this. Commonly, most people do plates. So you plate over the base of the first metatarsal and medial cuneiform, as well as the second and the third. You then also have to do a Lisfranc screw that goes from the base of the second metatarsal into the medial cuneiform. And this can be either retrograde or antegrade. Commonly, people are, as I said, instead of using just screws, putting plates to fix 1, 2, and 3. And quickly, we did a case at the beginning of my fellowship. As you can see, between the left and the right, this 61-year-old lady after her fall, she's got, these were weight-bearing views, and she's got a subtle opening in between the first and second rays. We then got a CT. And actually, it's not just a ligamental injury. There's a fracture at the base of the probably intermediate cuneiform and the base of the second metatarsal. And you've got that lateral view showing the subluxation of the cuneiform on the metatarsal. And once we went in there, she just needed a Lisfranc screw and fixing of the base of the second metatarsal onto the middle cuneiform, and everything else was stable and rock solid. So you don't need to go overboard. You just fix and stabilize what's unstable at the time, but have a sequential way of working proximal to distal, medial to lateral. And that's it.